is a member of the Committee of Environment and Women's Health. We will move on to our second speaker, Dr. Before I do, I noticed that quite a few of you, let me just reiterate, please turn off your cameras and your microphones. For those of you who are having trouble viewing the slides, please look at the view option on the topmost part of your screens and click side-by-side view so that you may see the slide and the speaker at the same time. So moving on, Dr. Rebecca Singson has been a practicing gynecologist, obstetrician gynecologist for 30 years in the Makati Medical Center, in Asian Hospital, where she is the vice chair of her department, and in St. Luke's Global City Medical Center, where she is the founding chair of the Department of Obstetrics and Gynecology. She received her bachelor's degree from the University of the Philippines in BS Biology, finishing magna cum laude. She graduated from the UP College of Medicine and completed her residency training in the Makati Medical Center. She trained in ultrasonography abroad in Europe. She pioneered gynecologic robotic surgery in the country after completing training in Celebration, Florida for robotic surgery, and thereafter became the head of the gynecologic robotic surgery program of St. Luke's Global City. She's well known, a multimedia personality, and has promoted women's health and public health in her website and social media platforms. This afternoon, we will hear her speak on the disposal of medical waste in the clinic and the hospital environment. Let's welcome Dr. Rebecca Singson.
Hello, good afternoon,
Hello,
everybody.
ma'am. Good afternoon.
Hi, may I share
Yes,
my
please.
screen right now?
We can see you, ma'am.
Na namamahagi ng tulong ang International Organization for Migration o
There is some background noise. I hope that will disappear. We can see your slide and you, ma'am. Please proceed.
Okay, it is my great honor to be here to present to you a topic that is of utmost importance and very relevant during this COVID pandemic and the years to come. I've been practicing OBGYN for over 30 years, and I'm at the tail end of a 2-year course in Masters in Hospital Management. And medical waste management was never really in our radar until now. Now, due to COVID on March 8th, the Philippines was declared under a state of public health emergency. The rapid surge of cases found us with increased healthcare waste, and so we need to deal with the proper management, handling, treatment, and disposal of these wastes, while at the same time, look after the welfare of all the users, patients, physicians, nurses, and other frontliners. Let us begin by defining healthcare waste or biomedical waste. The WHO defines it as waste that is generated within healthcare facilities, research centers, and laboratories related to medical procedures. It includes wastes that you generate in the home and in the course of undertaking healthcare, like home care dialysis, self-administration of insulin, and recuperative care. The major sources of biomedical waste are the following. The major sources are hospitals, labs, research centers, blood banks, nursing homes, mortuaries, and autopsy centers. Minor sources are clinics, dental clinics, home care facilities, cosmetic clinics, funeral services, geriatric institutions, and mental institutions. And if I may add, even barbershops, salons, and waxing salons are sources of biomedical waste. Research has shown that there is a positive correlation between the GDP of a country and the healthcare waste generation. And this is expressed as kilogram per bed per day of waste. As the quality of healthcare services increases, more medical equipment and more medical consumables are purchased, more patients are treated, and more healthcare waste is generated. This slide shows the waste generation per country. In Ethiopia, it's 1.03 kilogram per bed per day. In Argentina, it's 3. In Canada, it's 8.2, which means that they dispose everything. And in Italy, it's 4 kilogram per bed per day. And in the Philippines, According to the Integrated Waste Management, Inc., which is a company that specializes in biohazardous waste management, from the Lina group of companies like Air 21, Cargo House, Ube Express, which has the buses that transports people from P2P to the airport. According to them, the Philippines generates about 1 kilogram per bed per day of healthcare waste. Now, much of the data in the subsequent slides are from the DOH Healthcare Waste Manual and the DOH Memo 2020-0170 on the interim guidelines on the management of healthcare waste in the healthcare facilities, community quarantine units, and temporary treatment and monitoring facilities with cases of COVID-19. What are the categories of healthcare waste? First category is general waste. Now, this is comparable to domestic waste, mostly from administrative and housekeeping functions of healthcare. This would be paper, bottles, plastics, and food waste. This can be dealt with by the municipal waste disposal system. Second category is infectious waste. This is waste that may contain pathogens like SARS-CoV-2, bacteria, parasites, or fungi in sufficient concentrations to cause disease in susceptible hosts. This can come from cultures and stocks of infectious agents from the lab, waste from autopsies on patients who have infectious diseases, waste from infectious patients in the isolation wards, or infected patients undergoing dialysis. Category 3 is pathological waste, which come from tissues, organs, body parts, human fetuses, blood, and body fluids. Category 4 are sharps, needles, syringes, scalpels, saws, blades, broken glass, infusion sets, knives, and nails, which can cause a cut or a puncture wound. Category 5 is pharmaceutical waste, which includes expired, unused, spilled, and contaminated pharmaceutical products, drugs, vaccines, and sera that are no longer required. This includes bottles, vials, boxes with residues, gloves, masks containing tubings. Category 6 would be genotoxic waste. This is highly dangerous waste that can have mutagenic, teratogenic, or carcinogenic properties. This includes cytotoxic, cytostatic drugs like alkylating agents and antimetabolites, as well as the vomit, urine, and feces of patients treated with these drugs. Category 7 is chemical waste. These are discarded solid, liquid, and gaseous chemicals from diagnostic and experimental work and from cleaning, housekeeping, and disinfecting procedures, which can be toxic, corrosive, because it can be an acidic material with pH of less than 2, or very basic with a pH of greater than 12. They can be flammable or even explosive. Heavy metal waste is comprised of mercury that comes from broken thermometers or blood pressure gauges or residues from dental procedures. Cadmium waste comes from discarded batteries. Category 9 is pressurized containers. Many gases are stored in pressurized cylinders, cartridges, and aerosol cans. Number 10 is radioactive waste. These are materials that, such as excreta of patients who underwent radionuclide diagnostic and therapeutic applications. Now, if we were to show this in a pie diagram, it would look like this, where 80% of the waste in the hospital are really non-infectious. Chemical waste, usually from the laboratory, would be around 3%. Sharps would be 1%, and radioactive, cytotoxic, and heavy metal waste would be around 1%. Infectious and pathological waste would make up about 15% of the hospital's waste. Now, the proportion of your non-infectious waste to your infectious waste can tell if the staff is doing a good job at segregating. Because if this figure of 15% for pathological waste is bloated to like 30, 40, 60% of the waste, it means that there's either a pandemic, or if there's no pandemic, the doctors and staff are not segregating their wastes properly. To show this in an algorithm, healthcare waste can be divided into hazardous and non-hazardous waste. The hazardous waste is divided into infectious and other hazardous waste like radioactive, chemical, cytotoxic waste, and pressurized containers. The 15 to 18% of infectious wastes made of sharps, non-sharps, plastic, solid and disposable waste, as well as liquid waste, is all we will focus on in the next few minutes of allotted time. The other types of waste will necessitate another entire webinar for discussion. Now, the very first concept in waste management is waste generation. In short, walang kalat kung walang magkakalat. So the key overriding principle we have to bear in mind is do not create waste if you can avoid it. And secondly, if you must create the waste, find ways to minimize it. More than ever, this even has a greater impact now that we have a pandemic and we're consuming far more PPEs. We are double or triple gloving, using disposable masks. We're using surgical gowns and hazmats, disposable shoe and head covers, goggles and face shields, acrylic barriers, plastic covers. And the reuse and recycling of potentially infectious waste is prohibited during this pandemic crisis. This means that laparoscopic trocars and single-use advanced cutlery devices will be strictly used only once. And to think that as an intern in PGH, we were recycling gloves, but my son tells me it's still going on actually in many hospitals in the country. Now, what is the impact of all of these wastes in our environment, and how do we dispose these? Let me show you this slide, which shows the average amount of waste pre-COVID and the increase in tonnage of medical waste after COVID. This data is care of IWMI, which collects 30% of all the medical waste of Metro Manila. Of course, it's expected that RITM would have a massive increase of medical waste by 50 to 60% because it was the only testing site at the start of the pandemic. St. Luke's Global City increased by around 40%. Note that this is 80 to 90 tons. Sorry, that's January, February, and then it's supposed to be March, April. 80 to 90 tons is 80,000 kilos to 90,000 kilos because 1 ton is 1,000 kilos, okay? So St. Luke's Global increased by about 40%, St. Luke's QC by 20 to 28%. And initially, St. Luke's was handling the most number of COVID cases among the private hospitals. Asian Hospital increased by 17 to 23%, and Makati Med by 7 to 12%. Now, Lung Center increased by 28% just this April. East Avenue increased by only 4%, and NKTI, this is the National Kidney Institute, hardly increased because they actually shut down the hospital to non-renal admissions. So even if it were an emergency, if it was not renal related, the patient is referred out. That's why they have very little, or they did not increase their medical waste significantly. Now, we doctors are a very big factor in waste generation because we consume a lot of disposables in the course of management of patients. And if we can minimize waste generation in every little way, our collective efforts will translate to big outcomes. This is why I need to share with you this recommendation by the Philippine College of Surgeons based on the WHO and CDC guidelines. If you please turn your attention to the lowest category, patients coming to the clinic, they are safe to come only wearing a mask. 2 days ago, I had a patient, a pregnant patient who came to my clinic wearing full PPE, like she was going to incinerate medical waste. She was the only patient in the clinic and she didn't even have to use an elevator from her car to my clinic. And so I think it was a bit of an overkill, but she felt safe with it. So of course, that's always your discretion. The clinicians and nurses on the second to the last category can use either a surgical mask or an N95 mask plus a face shield. The gloves is even optional. Now, if you are a healthcare worker, that's the third to the bottom, from the bottom, if you're a healthcare worker transporting a COVID positive patient, you see this coronavirus icon here. That means this is if you are taking care of a COVID positive patient. All you really need is an N95 mask plus an isolation gown, goggles, plus minus a face shield and gloves. Now, if you're cleaning the operating room, this is actually the only time a hazmat coverall is recommended instead of an isolation gown. Note that all major surgeries require an N95 mask and a long sleeve waterproof gown, which were given in the operating room anyway. And if you perform the first two procedures from above, meaning the procedures on airway like endoscopy and CPR, or surgical procedures under general anesthesia, especially those around the head, you are not even required to wear a hazmat coverall. The WHO in an April 6 guideline says that the coveralls is required for Ebola, but it is not required for COVID-19. So you see that coronavirus icon there on the first category and the fifth category. So it means that even if you're operating on a COVID positive patient, and when you're doing surgical procedures on the GA around the head, all you need is a sterile, waterproof, disposable OR gown, which is usually furnished to us when we do surgeries. Note that the PCS, the Philippine College of Surgeons, just put a plus sign there beside the long sleeve waterproof gown recommendation, just to signify that you can always add a coverall, a hazmat to your PPE, just to be safe, but there is no such recommendation from the WHO or CDC. Also, it is only when you are operating on a COVID positive patient that you must wear goggles plus a face shield. Otherwise, either a face shield or goggles will do, and it is at your discretion if you want to use both. Apart from the fact that it limits our vision and breathing, it makes you perspire more on top of your coveralls, so it adds to our medical waste. It becomes more of a waste when it is not necessary. A COVID RT-PCR test is required at least in all my hospitals prior to any scheduled surgery, so you can know the COVID status of your patient, although we're aware that there are 30% false negative for the RT-PCR. Now, powered air purifying respirators or PAPRs may replace your mask, goggles, and face shield when you are handling a COVID positive patient or performing surgical procedures in the head under general anesthesia. So think about this when you gear up. I was just telling some doctors that my OBGYN friends in Columbia University in New York, which is an epicenter of COVID in the USA, and a friend in Sloan Memorial Kettering were laughing at me for delivering a COVID negative mother in a level 4 PPE, complete with coveralls, because they don't even use that when they're doing their robotic surgeries. So I do use the reusable coveralls, not the disposal one, at least to minimize the waste. But it's comforting to know that we can do without it altogether. Now, all healthcare personnel must ensure that waste generation from suspect, probable, and confirmed COVID-19 patients are properly segregated at waste generation points at the clinics, laboratory, radiology areas. COVID waste does not need any special treatment outside of the protocols we have for other infectious waste, so they can actually be mixed together. Now, appropriate labeling of waste bins must be done with signages to show that what type of waste must be used. You can also put posters on the wall to demonstrate what type of waste should be thrown in that receptacle to guide the staff. You just have the proper receptacle for general waste, infectious yellow waste, and sharps. These must be collected when the bins are 3/4 full and must be sealed prior to transport. Now, there are many color codings out there for waste bins in the world, but I'm showing you the one that's recommended by the RDOH. Black bins are for non-infectious dry waste like paper, plastics, and bottles. Green is for food waste. Yellow is for infectious pathologic waste. Yellow with a black band is for chemical and heavy metal waste. Orange is for radioactive waste. Red is for sharps and pressurized aerosols like your air freshener, Glade Mist, Pledge Cleaner, even the Freon cans for aircon, and oxygen tanks. Infectious waste must never be mixed with other non-infectious wastes. And should a staff make a mistake in the segregation, they should never try to correct it by removing items from one bag to another. If you accidentally throw infectious waste in a non-infectious bag, you must label that as infectious. Now, transport of the collected infectious waste must be done using wheel trolleys or wheel bins. You have to assign a utility lift, which must never be used for food trolleys. Routes for transport of infectious waste from patient areas to storage should be established by the health facilities. And dedicated trolleys and carts must have separate waste routes for transporting hazardous and non-hazardous waste, and should be planned such that a waste trolley should never cross with a food trolley or pass a sterile area. Now, infectious waste generated may be stored temporarily in designated locations, identifiable by a biohazard symbol. And it must be sun-proof, rain-proof, wind-proof, flood-proof, kahit hindi earthquake-proof, pwede naman. Pero imagine if there is a storm that comes and blows away to the entire neighborhood, the blood-filled gauze and needles and syringes and septic gowns, that would be disastrous. It must also be inaccessible to animals, insects, and birds, and most especially bats. In other words, far away from patients and public places, away from fresh food stores or food preparation areas. That's why usually the central storage of infectious waste is at the basement area. Now, the waste management company must fetch the infectious waste within 48 hours during a cool season or 24 hours during a hot season. In other words, the company like IWMI must pick up the infectious waste within the day. And they cannot compact it, unlike municipal waste. From the hospital, the waste is picked up by companies specializing in medical waste. And I'm told there are about 5 in Metro Manila, although the IWMI takes care of 30% of the lion's share. Their waste specialists come in full PPE with boots, gloves, impermeable hazmats. Now, this is how our municipal waste is transported. You've seen their trucks pick up the garbage at home, and it's open, an open truck, sometimes even overflowing, but they take care of 80 to 85% of the non-hazardous waste. In contrast, medical waste is used as enclosed trucks, and transportation takes place during the less busy times of the day, usually midnight. And all these infectious waste that they pick up must undergo a treatment before it can be thrown into the landfills. Now, in the Philippines, we have 2 modalities of treating infectious waste, either by autoclave or by pyrolysis. Autoclaves are enclosed chambers that apply steam heat at 250 to 400 centigrade and pressure at 30 pounds per square inch. For medical waste to be disposed of, autoclaves can be used as heat treatment processing units to destroy microorganisms before disposal in a traditional landfill. Autoclaves are chemical-free, and that appeals to many stakeholders in a complex waste management environment. They are not for any waste that might undergo a chemical reaction or any bulk or any waste that might go into combustion and give off substantial gas. They can be used to process large bulk of infectious waste at a hospital or clinic up to 20 tons per day. What can you not put in an autoclave? You cannot put heavy metals and expect them to be not hazardous when it comes out. You cannot put human tissue or animal tissue because these have lower thermal conductivity than metal, so a longer time in the autoclave would be required than for surgical instruments of comparable size. And there's also concern that autoclave pathological waste might contain low levels of radioactive material or cytotoxic compounds that has survived the heat. In any case, the rules and norms in most parts of the world call for pyrolysis of pathologic waste. Now, waste materials may be treated by incineration or by thermal processing in the absence of air or oxygen in a process called pyrolysis. It results in a complete destruction of hazardous waste through a 10 to 16-hour process, resulting in a 10% reduction of waste volume for final disposal. It is environmentally friendly. Now, step one involves loading the hazardous waste into the primary chamber for thermal decomposition. So if I can show you, the left and the right squares are primary chambers, and the cylindrical one in the middle is a secondary chamber. So after you load the hazardous waste in the primary chamber, it undergoes decomposition, and the waste is separated into combustible gas and inert ash. The gases that are produced are sucked into the secondary chamber to be destroyed and detoxified, while the ash is left in the primary chamber. And then the leftover ash is collected and disposed of in a sanitary landfill. Now, a sanitary landfill is an engineered facility that separates and confines waste, and they are intended as a biological reactor in which microbes will break down the complex organic waste into simpler, less toxic compounds over time. So cavities are dug out of the ground, and then the walls are sealed with layers of clay and coated with plastic to prevent groundwater contamination from wastewater that accumulates. All medical waste is brought to the landfill of Metro Clark, which is the most properly constructed landfill in the country. By the way, there are only 108 landfills in the entire Philippines, when we need at least over 1,100. So this is one of the top priorities of the Duterte administration, to build more landfills. After all that's been said, what is another reason why we should segregate non-infectious waste from infectious waste? Because the cost of processing infectious waste is infinitely higher than processing municipal waste. The cost of municipal waste, you see, is 1.5 to 2 pesos per kilo. An autoclave treatment is 13 to 15 pesos per kilo of waste. Pyrolysis is 25 to 35 kilograms of waste. So if you're processing 80,000 kilos at 25 pesos per kilo, that's like 2 million pesos of waste within a month. So in summary, as physicians, we need to be educated on proper segregation and waste management. We need to make sure the staff and our patients, when they are confined, are also cognizant of the fact that they should not mix their food waste in the infectious bins, because it would increase the tonnage of our medical waste. Increased tonnage means increased expenditure in waste treatment. We have to find ways to minimize our waste generation, because we live in an ecosystem, and what we generate impacts the ecosystem. If we all did our little effort individually to reduce our waste collectively, we would reduce it for the community and cut our costs. Since there is no recycling of medical waste, the best we can do is to minimize it from source. Finally, let not the waste of the sick contaminate the lives of the healthy. Thank you very much.
Thank you, Dr. Singson, for that informative lecture on the management of medical waste, such as PPEs, as we continue to deal with COVID-19.